everyone. Thank you for joining us today. My name is Hannah, Office Coordinator for the National POLST Paradigm Office. Today, Dr. Suzanne Labriola is presenting the POLST in Hospital Toolkit webinar, which is part of the National POLST Paradigm Toolkit webinar series, using the POLST paradigm to honor patient treatment wishes across the care continuum. We would really like to hear from you today, so if you have any questions at any time, please go ahead and type them in the chat box, and we will answer your questions during the presentation and also at the end. Also, this webinar is being recorded along with our previous webinars, and you can find all these recordings at polst.org/toolkit. We also have 2 more upcoming webinars in June, and you can register for those webinars at polst.org/toolkit as well. Now I'd like to introduce our presenter, Dr. Suzanne Labriola. Suzanne is a board certified in internal and palliative medicine, and currently she is the Chief Medical Officer at Allegheny Valley Hospital in Pennsylvania. Suzanne also serves as Chair of Advanced Care Planning at AHN and has championed POLST education. Suzanne?
Thank you, Hannah, for that introduction, and thanks everybody for joining. My chapter was on the hospital inpatient toolkit. I don't have any disclosures, but we are going to talk about the elephant in the room today. The goals for this part of the toolkit are to describe the POLST paradigm in the hospital setting, to identify the benefits of adopting the POLST paradigm for inpatients, to provide a pathway for implementation, and provide resources for education. So the previous toolkit presentations have talked about POLST paradigm in general, POLST use in primary care, and with EMS and trauma, and now we're at the hospital setting. Although we see this as a continuum of care, we realize too that patients can also step backwards on the care line, going from a nursing home back to EMS, back to the hospital. So it is a true continuum of care. Here's an example of the Pennsylvania POLST form. There are different form versions in different states, and the national version available at polst.org. So let's start by talking about the POLST paradigm in the hospital setting. Patients in the hospital will present to the emergency room with a POLST. They could be directly admitted with a POLST form, or they may complete a POLST form during the hospitalization prior to their discharge. If a patient presents to the hospital with a POLST form, the form will indicate either full treatment, and that's what we consider the standard of care, a patient who accepts all life-sustaining treatment and CPR. They may have selected limited intervention. This is a patient who does not want to be in the intensive care unit or intubated, but they may be willing to accept BiPAP. And they want more than just comfort measures. Or a patient may have selected comfort measures only. This patient could present through the emergency room with symptoms that could not be controlled where they were. Or a patient who is leaving the hospital who has selected comfort measures only may indicate the desire to not return to the hospital for life-prolonging care. So when we talk about standard of care, I said that this is full care, and that our standard is that we do everything possible to attempt to save somebody's life during the medical emergency, unless there's a medical order to the contrary. This patient may have an advance directive or a living will, but it's not yet activated. Patients who have advance directives and living will, who are interested in activating and beginning to follow the wishes that were outlined, need to have a discussion for those wishes to be acted upon. So a patient may have a healthcare power of attorney, a surrogate that has been designated, or a living will. But until that discussion takes place, these wishes have not been entered into a medical order. A medical order may be in the form of a DNR, or a do not resuscitate, or a POLST. These are forms that hospitals can act on, but that they must be translated to inpatient orders. So why is advanced care planning and the POLST paradigm important for hospitals and your patients? Because we know that the report on Dying in America showed us that in 2009, 28% of Medicare patients died in a hospital. 29% had at least one ICU admission in the last 30 days, and 69% had at least one hospitalization in the last 90 days. So what are the perceived barriers to advanced care planning and the POLST paradigm? And how can we help improve our patients' care and ensure that we're honoring their wishes and their care? From the patient standpoint, it's a very personal conversation. It may elicit strong emotional reactions. There may be conflict about who would make their decisions and how decisions can be made. It's difficult making decisions regarding advanced care planning when medical treatment should be continued or foregone. From the healthcare professional's view, it may be unclear how to start the conversation. It may raise issues that are difficult to resolve. We often hear it requires too much time, or think that somebody else will address the problems. And from a hospital standpoint and the institution or the system, the documents may not be available. Instructions in the documents may be either too vague or too specific and not available when needed. And efforts to reopen the conversation when there's a change in care or a change in location of care are rarely made. So adopting the POLST paradigm can help to solve some of these barriers. The benefits of adopting POLST for the hospital: it will clearly establish the patient's or the surrogate's decision for the level of care. Establishing attainable goals for care helps the medical team develop an individualized plan of care. This can improve the patient and the surrogate experience and the level of satisfaction with their care. You can see HCAHPS ratings improve, as well as quality measures. And when previous conversations on goals of care are documented with a POLST form, this saves time for the staff as they're able to review the form and confirm its accuracy instead of starting a conversation from the beginning. It will increase staff's comfort with difficult conversations, and the staff may also find less moral distress, as they will not have to perform CPR on patients who would not benefit from it and have chosen not to receive it. It may also decrease hospital readmissions. Moss and his team documented this decrease in the Journal of American Geriatric Society in 2016. It could also decrease length of stay, so all things that hospitals are focusing on at this time. So how do you begin, and what is the pathway that we suggest for implementation? First, you'd like to establish a core working group with broad representation. You want to identify a physician champion, involve nursing leadership, quality and safety officer, director of case management and social services, palliative medicine if they're available at your hospital, and your legal and ethics counsel. This team will need to review, update, or modify policies on advanced care planning and writing orders for life-sustaining treatment to support the goal and the POLST paradigm. The working group will need to address the admission process, the discharge process, how billing will be done, also tracking of the POLST discussion and forms, as well as education. So for the admission process, on admission, in addition to inquiring if a patient has an advance directive as is required, we also would want to confirm if a patient has a POLST form. You need to establish that POLST forms can be accepted from out-of-network physicians and extenders, and how to translate a POLST into a hospital order. This will be determined in a policy that will identify who is responsible for translating the POLST into the medical order and whether or not verbal orders will be accepted and under what circumstances. We must always ensure that the physician of record is reviewing and confirming the POLST form to be accurate. The POLST conversation may be had by the physician of record, the palliative medicine consultant, a social worker, an advanced care planning facilitator, or a chaplain, depending on how your hospital is set. Prior to implementing the pathway, you also want to make sure that there's a consistent place where the POLST form will be kept, whether this is a paper chart or an electronic medical record. For the discharge process, policies will also need to be reviewed to confirm who will ensure that the POLST form remains accurate or offer a POLST form after a conversation on the goals of care, to ensure that the POLST form travels with the patient, and to engage local EMS and SNFs or LTACs in the POLST paradigm. Now, at this time, I'm taking a little change in our course for a moment to discuss a code status versus a CPR status, as this is important in translating POLST to an inpatient hospital order. The concept of code status can lead to incongruous orders. The list of options presented allow for patients or their surrogate to select a chemical code where medications are administered but no chest compressions or airway, or a case where a patient or family selects a do not intubate but okay for chest compressions. We know that medically these will not be effective when a patient has lost their pulse or their airway. DNR does not tell the whole story. DNR is not applicable in an emergency when the patient has a pulse and is breathing, but is unable to tell us what their goals are. A DNR does not automatically mean do not intubate. A review of POLST forms from the first year of the Oregon Pulse Registry shows that only 50% of patients with a DNR order also wanted to go to the hospital. The other 50% want comfort measures only and choose not to return to the hospital. It's also difficult to translate POLST into a code status order set. This is because the POLST form clearly separates CPR from additional medical orders. This is unfortunately the current code status set that we have in the Allegheny Health Network. The options are confusing even at present. We know what comfort measure only means, we know what DNR means, but we're not sure how to apply that to an emergency setting where a patient has a pulse and is breathing. We know what full code means, and that's the standard of care, but we're not sure what partial code means. POLST form, however, can give us very clear separation of goals and what to do if a patient has a pulse and is still breathing. For full treatment, the patient wants a standard of care. They want everything done to prolong their life, including ICU care and ventilation. In limited treatment, the patient wants to go to the hospital if it's necessary, but prefers to avoid the intensive care unit and does not want to be intubated. And comfort measures only means that the patient would want to stay where they were and have their symptoms treated. So adopting a program and a practice where we eliminate the concept of a code status and accept the concept of CPR status linked to additional medical orders and intervention helps to clarify the patient's goals and addresses the level of care while they're hospitalized, of following POLST and making it easier to translate into an order set. What we had proposed at our hospital, again, is to remove the antiquated term of code status, replace it with CPR status linked to medical interventions. CPR status would apply only when a patient has no pulse and is not breathing. The option would be yes, attempt CPR, or no, do not attempt CPR, with medical interventions being an option of full treatment, limited additional interventions, or comfort measures only. We're comfortable with what full treatment means. We know that it means we're using intubation and advanced airways, mechanical ventilation, and cardioversion is needed, that transfer to the intensive care would be used as medically indicated. But if cardiopulmonary arrest occurs, then we would refer to the order regarding CPR status. We're also comfortable understanding what comfort measures only means. We would use medications by any route, positioning, or wound care, and other measures to relieve pain and suffering. We'd use oxygen and oral suction and manual treatment of airway obstructions as needed for comfort. However, limited additional interventions may need to be more specific than is just outlined on the POLST form for patients who are admitted to the hospital setting. In the event of severe cardiopulmonary deterioration, the goal of care are to maintain cardiopulmonary function to prolong life up to the point of cardiopulmonary arrest. The patient should not be intubated in the event of respiratory and/or ventilatory failure. CPAP or BiPAP may be considered. However, patients want to avoid the intensive care unit if possible. If a cardiopulmonary arrest occurs, we would refer to the order regarding CPR status. Now, just like when we're completing a POLST form, we do not allow patients to select yes, attempt CPR, but limited additional interventions for medical interventions. We would not allow that to happen in an inpatient order set either, because we would not allow a patient to progress to cardiopulmonary arrest without intervening and then intervene at that time. So in this case, their CPR status, if they had selected limited additional interventions, would have to be no, do not attempt CPR. If the patient wishes to limit the treatment of hypotension or heart rate, it might not be appropriate to transfer them to a critical care unit depending on your hospital policies, and telemetry might not be indicated. So here's an example of how we've proposed in our system to change to a CPR status. We are an electronic medical version in some of our hospitals, an electronic medical record at some of our hospitals. So we could enter an order for CPR status as yes, attempt, or no, do not attempt. And it would be linked to our order set. Our new order set linked to additional medical orders clearly separates what we would offer during a cardiopulmonary arrest from what would be offered in a medical emergency when the patient still has a pulse and is breathing. So at this time, I can pause and see if there were any questions. Get back to our path for implementation. We discussed the admission process and the discharge process, and next I'd like to talk about billing.
And Suzanne, actually, we did just get a question in, if you don't mind pausing for a moment. Sure. A question came in: how often has a POLST or MOLST not been followed? Don't know.
Hannah, I know we have that information from one of our previous presentations that Amy did originally on the POLST.
Yeah, I can definitely look into the information back to you after today's presentation. I'm
now going back to our a slide to our new proposed order sets. And she asked, how do our providers feel about the hard stops? It was presented to our system critical care committee, presented to all of our MECs. We had it reviewed by ethics and by legal. So it was a group and a team approach to develop this. We have removed dialysis from a required hard stop field in the new changes that were made, but the rest of our teams and our physicians agreed that these were important questions to know so that we knew how to appropriately respond during a medical emergency and a rapid response team. So once we engaged the right groups, it was easy for them to understand and to accept. We have not gone through the education, and the order set has not gone live yet for us, but I could definitely let you know how it goes after we implement it. Okay. So in regards to billing for advanced care planning, physicians can now bill for these discussions. These codes that were released by CMS require a face-to-face visit between the billing provider and the patient. They are time-based, so time is the most important item to be documented. It must be a minimum of 15 minutes and can include assisting the patient or the family with completing paperwork in addition to the time explaining them. So completion of a POLST form can be used as part of this documentation. It is important to note that no active management of the problems can be done during the 30 minutes of time reported for this code. The codes are 99497. This is for the initial advanced care planning, including the explanation and discussion of advanced directives, such as standard forms, by the physician or other qualified health provider, face-to-face with the patient and family members or surrogates. This is must be over 15 minutes, so I have seen it documented 16 to 30 minutes, and then 99498 for each additional 15 to 30 minutes after the initial 30 minutes. These codes do not have to be billed on the same day, can be on subsequent visits. When these codes are linked to a wellness visit, there is no charge to the patient. I saw a question come up again. How often can providers use this code? It's once for the initial code, and then subsequent additional code can be added on anytime you go back to review advanced care planning. Again, it doesn't have to be the same day. So tracking. How do we track our POLST? For hospitals still using paper charts, the POLST documentation should be placed in an advanced care planning section, but if not available, although it's not an advanced directive, it should be placed in the advanced directive section. It is a medical order. For hospitals with an electronic medical record, the electronic medical record presents additional opportunities to enhance the POLST paradigm implementation across the care continuum. The National POLST Paradigm Task Force strongly recommends that EMRs be designed so that POLST forms are located in a unique field or tab that can be accessed instantly in a single click. The EMR should link inpatient and outpatient advanced care planning documents. If a patient has a POLST form on file with the system, it should be readily accessible and known to all healthcare providers. For tracking, completion of a POLST discussion or a refusal of such discussion and form should be documented using the following tracking codes, in addition to the standard billing codes. Neither of these codes generate an additional charge, but are used to capture the information. The CPT2 code of 1123F documents that a POLST discussion with POLST completion has occurred. CPT 1124F documents that a POLST discussion was offered without POLST completion. We can also use that code if a POLST is already in place and does not need to be changed. Tracking can also help with POLST compliance. So to return to the earlier question of how often are POLST forms honored, this would be a way to offer research and improvement to ensure that compliance is happening and that we are honoring patients' wishes at the end of life. POLST discussion and documentation can also be tracked with the use of smart phrases and advanced care planning standardized documentation. Here's an example of how to insert POLST into a note that can be pre-populated. Here I noted that the POLST was introduced and reviewed with the patient, family, or caregiver that can be selected, and the POLST was or was not completing during the consultation, and what the patient and the family has elected can be added. This is an example of a paper form to complete on advanced care planning and the POLST discussion. It can say who's been involved with the discussion, the questions that were answered for the patient and their surrogate, and where they are in the level of their decision making.
Examples of notes or order sets in Cerner or only Epic?
We are still trying to get the Cerner examples. I had the Epic examples because it's the program that we've been using in my hospital system, but we will be looking to add Cerner references to the toolkit that will be available online. The paper form that I used and referenced is available through the Pennsylvania POLST and can be accessed through the National POLST website by clicking on Pennsylvania and then looking at the resources under the Pennsylvania tab. So back to our implementation process, we want to make sure that we're offering education. The education on the POLST paradigm should be offered to all staff with direct patient care. We want to offer enhanced education for staff participating in the POLST paradigm and form completion. This should include practice scenarios. Education materials are available through the National POLST Paradigm website and the state POLST programs. I'd recommend that yearly CME and CEU requirements be added in advanced care planning. And if you do have a program of graduate medical education, engage your medical students, residents, and fellows in POLST paradigm and POLST form and how to complete them. But education on the POLST paradigm does not stop with the introduction of a POLST form. Ongoing education should be focused to the hospital needs, and we can complete a POLST knowledge assessment to ensure that we're focusing on the right topics for your particular hospital. Resources are available through POLST.org and the Toolkit for a knowledge assessment that can be used, as well as reference links for education. In Pennsylvania, we have many resources, again, through our website and the National POLST.org website. We have a training manual CD, and there are videos nationally as well as in Pennsylvania on POLST in action. So thank you for your interest and participating in the webinar today. We welcome feedback and comments. You can email us at toolkit@pols.org, and Hannah would be able to connect you to me. I'd like to thank the Pew Charitable Trust for supporting our Toolkit program and the webinars. And I'll look for more questions online now.
Great. Thank you for that wonderful presentation. And yeah, we can just hold on for a couple of minutes to see if more questions come in. I see one other question. Does Pennsylvania honor POLST forms from other states?
Yes, I can speak for our network and for the Pennsylvania area. I work outside of Pittsburgh, have been in the Pittsburgh area. We're part of the tri-state area. We do have patients come from West Virginia with POLST forms, from New York as well. And yes, we would honor those forms. And again, just ensure that we translated them to inpatient hospital orders after we had a discussion to make sure that they were still accurate in their documentation of the patient wishes. I also complete POLST forms here in Pennsylvania with patients who I know are going back to their home, be it in Ohio, West Virginia, or New York.
Dan, I was wondering, in some states, CPR and limited is allowed as an order combination on POLST forms. And I was just wondering what a medical professional would do in this instance if they saw a POLST form with this order combination.
That would be difficult because CPR together means that we would use airway securing and compressions. So if a patient had selected limited, then they would not want to be intubated, and I think it would be more discussions and education that without a secure airway, chest compressions and defibrillation is unlikely to be successful.
The other question, do you have information about what types of educational models work best with staff?
What I have always used is case presentations. I think has been helpful for patients, for the staff that's actually engaging with the patient and having the conversations. What we've done is made the education very easy and accessible with online modules so that we can track completion and compliance with them so that our general staff at large can complete them in their own time.
States accept other POLST forms, meaning reciprocal relation, a legislative guide on our website that I can send you the link to. But if a POLST is in legislation in a particular state, then we have a guide or a chart listing all the states that accept out-of-state POLST forms. EMS will follow this CPR order in Hawaii and do full treatment. Oh, that might have been in response to my question about the CPR limited combination. Thank you.
It makes it much easier for EMS and for hospitals to, honor that wish when patients who elect CPR have elected full treatment. And in Pennsylvania, that's the only way it's allowed to be completed.
Jersey. In New Jersey, we have that combination. We use limited as conservative measures. We treat and in the event of arrest do not initiate CPR. For example, advanced dementia with PNA will treat with IVF and antibiotics. This declines, then no intubation or resuscitation.
That's exactly the way that I practice with the POLST in Pennsylvania too. That for a patient with advanced dementia who suffered from pneumonia, we'd estimate that her chances of surviving CPR with a good neurologic outcome would be very low, but that with a pneumonia, it may be potentially reversible. So treating that with antibiotics, with CPAP or BiPAP may be appropriate, but should that patient progress to respiratory failure or cardiopulmonary arrest, then we would allow that patient to have a natural death. Patients can also select no, do not attempt resuscitation with full treatment. So in that case, if a patient had a condition that could be potentially reversible, like heart failure and hypoxia, they would elect intubation for full treatment. But should they continue to decline to cardiopulmonary arrest, we would not intervene with chest compressions and defibrillation at that time.
Today, and I think it would be worthwhile just to hold on for a couple more minutes to see if any others come in. But otherwise, Again, feel free to email us, and I will get you connected with Suzanne if you have specific questions for her. Probably safe to end the presentation today. Do you have any last comments, Suzanne?
No, I just wish everybody luck in the implementation. Okay. And you can continue to check the toolkit for resources and guidance and reach out to any of the authors for the other sections as well. And we'd be happy to offer what we've found through the implementation ourselves, challenges and best practices that we've found.
All right. Well, thank you, everyone, for joining in today, and have a great rest of your day.